Welcome to Blunt Dissection, the podcast where we take clinical topics and cut through the noise to what actually matters for GPs. I'm Tom Gillham, a practising GP and Associate Medical Director for Primary Care at East and North Hertfordshire, teaching NHS Trust. Each month, I sit down with a clinical colleague from the Trust to unpack the issues that land in primary care, often at the worst possible moment, and work through what to do next. Practical, honest, and to the point. This is Blunt Dissection. In today's episode, we'll be tackling a 3-syllable word which can certainly set alarm bells ringing. I'm talking, of course, of tinnitus. A common presentation in general practice, often anxiety-provoking for patients and sometimes tricky to manage within a short consultation. I'm thrilled to be joined today by Miss Marie Lyons, who is an ENT consultant at East and North Herts Trust. Thank you so much for joining us today, Marie.
Thanks, Tom. Absolute pleasure to be here.
Okay, so we're going to start with a basic question. What is tinnitus from a clinical perspective?
So tinnitus is a perception of noise by a person where there's no external stimulus. So there are two types you can start with. There's subjective and objective. Most of the tinnitus is subjective, i.e. nobody else can hear that outside you.
Yeah.
Very occasionally it can be objective, and I've had patients come and say their husband or partner can hear the tinnitus. That is a very different scenario because there's usually some vascular thing going on at that stage.
Okay.
However, what we're more interested in is subjective, and that's much more common.
Yeah, and that's the common stuff we're seeing day to day in general practice. I've got a ringing in my ear, a noise, that sort of thing. Okay, so how do you kind of frame it as, or how do you pitch it to reduce patient anxiety about that symptom without dismissing it? Because often we're like, it's just a ringing in the ears, but that can be quite dismissive. How do we frame what's going on to patients?
I mean, we might think of it as, it's just ringing in your ears, but it can be very distressing to patients, and it can keep them awake. I think the first thing to say is, yes, it is very common. 15% of the population have tinnitus. So, and actually why I try to frame it, it's amazing we all don't have tinnitus. If you look at the anatomy, our hearing nerves are very close to the carotid. There's a lot of nerve energy going on there. So I think a lot of the time we lose that filtration mechanism, and that's what the tinnitus is. And I think making it that actually, yes, it's recognised, we know it's there, and recognising that it can cause quite a bit of distress.
Yes, absolutely. Okay, so we know what it is. We know it shouldn't be dismissed because that doesn't help the scenario at all. What about red flags? There are things that I, in my practice, think, oh goodness, is that particular thing there? Is that there? I try and rule things out. What features would you say sort of prompt an urgent or 2-week wait referral?
I mean, when I say 2-week wait, I think very little requires 2-week wait.
Okay.
But you will need a referral up on the same day or within 24 hours. The thing that I'm very interested in is if there is unilateral sensorineural hearing loss at the same time. I get concerned about that because we need to start the treatment as soon as possible, ideally within 24 to 48 hours. And it is something we take very seriously. Also, if there's any accompanying neurology, obviously is the patient having a stroke or severe headache, which you probably take very seriously in the first day, but we definitely would be interested in that. Pulsatile tinnitus of itself, not necessarily a 2-week wait, but we'll probably talk a bit more about that later.
That. Sure. So sudden hearing loss from nowhere, and again, just educate me here, Marie. What could that be a sign of? Sudden hearing loss on one side.
So sudden sense, we don't know what causes it most of the time, but steroids seem to work if they're given straight away. And unfortunately, I've seen lots of patients, they come to see us 2 and 3 months down the line and we've missed the boat by that stage. So it's seen as a medical emergency, sudden onset hearing loss. Obviously, I mean, sensorineural, not conductive.
Yes.
So obviously they don't have wax.
So sudden sensorineural loss, it's gone straight up to ED, and then you'll see them, and then you'll initiate steroid treatment, which can allow the hearing to come back.
Yeah, it does. And obviously we would arrange MRIs and things that need doing at that stage.
Okay. And then unilateral symptoms, obviously important, you mentioned that. So let's get back to this pulsatile tinnitus again. When I'm sitting there in clinic and someone's saying they've got an alarm bell ringing and it's kind of zzz, zzz, and they almost do the sound for you. And I'm like, oh my goodness, is there some massive aneurysm about to kick off? And how much time have I got to sort this out? And I do instinctively think this needs to go up quickly. But I think you alluded to the fact that that's rarely concerning, really.
Well, I think 2-week wait, we say, is synonymous with cancer. I have never I've been doing ENT for 30 years now, seen any sort of cancer present like that.
Yep.
I mean, I think the first thing to rule out is sometimes you can hear your heartbeat if you have a conductive hearing loss. So if it's a conductive hearing loss or pulsatile tinnitus, I'm not so concerned about it. But I think, again, if you have pulsatile tinnitus, you can hear a carotid bruit. You are a bit more worried at that stage because they could end up having a stroke eventually. So that would probably need to go vascular-wise than ENT-wise.
Yeah.
But other than that, I think they definitely need seeing, they need a hearing test, they need imaging of some kind, either an MRA or a CT with contrast, which, again, we can sort out in ENT.
Yeah, so if someone's got pulsatile tinnitus, it's reasonable to make a referral, but rarely, if ever, has it been something devastatingly awful. It's something actually which can be managed with routine referral.
I'd probably say maybe urgent, I suppose. What we're looking for is either a vascular tumour, again, which doesn't grow very quickly, or an AV malformation. But if you've got no other neurology, I think urgent, but I don't think 2-week wait is urgent. Urgent.
And they're normally seen within a couple of months on an urgent basis, East North Wales. Yeah. I won't hold you to all the figures at the moment. That's fine. That's fine. Okay, we haven't got loads of time. We're not ENT specialists. What does a good tinnitus history look like?
Well, 30 years into ENT, I actually have my ear questions, nose questions and throat questions. So you can get through the ear questions pretty quickly. Okay. So basically, and I ask these, whoever comes in, they get exactly the same questions and obviously exploring more. So tinnitus, when did it start? How long has it been there? Is it keeping you awake? And I think focusing on the mental health side is actually really important for these patients. And then the other ear questions are, do you have pain in your ear? Do you have discharge? And do you have room spinning? Because again, that will lead me to, how worried am I? Because if you've had hearing loss and the room's spinning around you and you have tinnitus, you're thinking, hang on a second. They definitely need referral, I would have said, in that situation. But obviously if they've got discharge, then you're looking infections and things like that. So, you can ask those 4 questions in sort of 15, 20 seconds.
Yeah, and I think just reiterating that point about mental health, you've mentioned that a couple of times, and there am I worried about an aneurysm, and actually that's really not that's not likely at all. What is very likely is that they are going to have psychological issues linked to tinnitus. So I don't know if I ask about that enough, frankly. Okay, what about examination? I know you've got something that I vaguely recognise from my medical school days on the table. A fork-shaped implement. Talk me through an examination you think it's reasonable for a GP to do in primary care.
Yeah, I mean, the main thing, again, I know I keep banging on about the unilateral hearing loss, but it is really quite vitally important that we treat that. Yeah. But obviously we don't want to send up every hearing loss because it might be conductive. So do you want me to demonstrate on you or myself?
I'd love you to demonstrate. Can I be your
I'll be
your tinnitus patient, if that's okay? Yeah, lovely.
So what we're going to do is do Rene's and Weber's test.
Yep, okay.
So Weber's test shows and I'll probably get told off by the purists, I tend to do it on my elbow. And
so you bang the fork on your elbow?
Elbow, yeah. So it doesn't have to be incredibly loud. But then this is Weber's test, and I put it in the centre of the forehead, and with some pressure, and you say, do you hear this louder on the left, the right, or in the middle?
So I can hear it in the middle?
In the middle.
Is that...
Which is correct.
Good news.
Excellent. So then you know which ear you're looking at. Because if you've got a conductive hearing loss, you'll hear it louder on the affected ear.
Yes.
If the nerve isn't working, you hear it on the unaffected ear. So that will allow you to tell whether it's conductive or sensorineural to some degree.
Got it.
So and then we do Rene's test. So again, so this is number 1. This is on the bone at the back of the ear, and this is number 2. Which one's louder?
Could you go again, please?
Yeah, certainly.
And
sometimes you go.
Number 1, number 2.
Number 1 and number 2.
And I'd say air is slightly louder, but should they be the same?
No, air should be louder. So I think everything is fine.
Everything's fine. Good. I'm going to live to see another day. That's great news.
Yeah.
So that was Rene's.
Yes.
So Weber's on the forehead. Rene's behind the ear.
Yeah.
Fantastic.
And air should be better than bone. If bone is better than air, you've got a conductive hearing loss.
Yeah.
And if basically the sound on the vapours goes to this side and it's better on the bone at that side, you've got a conductive hearing loss on that side. If it goes to that side and it's normal on the other side, or they can't hear it at all, it's much more likely to be sensorineural.
Okay. I'm going to go through that again once I watch the recording, so I learn that, because I have not done it for so many years, but thank you, and I'm slightly ashamed I haven't done it for so many years, but I will do it going forward. When should we, just going back to, when should we refer to audiology rather than ENT directly?
I think if you've got bilateral tinnitus, potentially, and you've got hearing loss, and in an older person, basically, I think the criteria for direct referral is over 65. I haven't looked at it recently, but I think it is about that. Because it isn't always the case, but many people with tinnitus have got hearing loss. And actually sometimes a hearing aid can be enough to sort it out. Right,
okay. So that brings us very neatly, thank you for the segue, into management. It's where expectations can be quite difficult, because obviously they just want the noise to go, don't they? What actually works? So when I'm seeing a patient with ringing in the ear, what can I tell them? I'm going to refer you because I know there are cures for this. So talk me through the options.
So I think, it's very important to say we can't cure it, because as far as we know, there isn't a cure. I mean, theoretically, you could cut the nerve of hearing, but you may still have tinnitus, and then that's a bit over the top. But it doesn't mean there's nothing we can do. I've had patients really distressed when they said there's nothing we can do, go away. And that is not the case. That is neither true or kind, if I'm honest. So a lot of it is explaining what tinnitus is, what causes it, and it's thought to be nerves sort of misfiring or firing in the same direction. And it is about management of it. So the whole point of it is you try to tune it out. And when people say, does it go? I don't know the answer to that question. It either goes or people tune it out. And I'm not sure how you could even figure out which
so
it is.
It goes with therapy and things, all patients are just less aware of it. It's less intrusive to their lives.
Okay. So it's things like, and the thing I focus most on is sleep. If it is affecting their sleep, that's horrible. It's torture. So a lot of patients have actually figured this out by the time they come. They have a detuned radio, or they have the TV on at night, or they have an audiobook. And actually, that does help. There are some apps on your phone as well. Sleep Pillow is one of them. So they are definitely worth looking into. But I think the other thing as well is to try not to focus on it, because the more you focus on it, the worse it tends to be. And a lot of patients say, does stress cause it? I would say probably not, but it certainly doesn't help. I think if you have it, stress is very difficult.
Yeah. And do you find often that the tinnitus settles down, or the perception of the noise settles down, once patients have been down that treatment journey? So they've come to see you, they've had a scan, or they've had some audiology intervention. Do you find that often that reassurance that it's not a brain tumour actually dampens the noise?
I think it does. It certainly does help. Or even if it doesn't dampen the noise, it makes people less bothered by it. Because I think, you always have that anxiety. Whereas only 4 out of every 100 MRIs we request come back with anything. I think knowing that is really helpful.
Absolutely. No medical intervention? Tablets don't work?
No, and in fact the NICE guidance suggests that we don't give beta-histine for tinnitus per se. Obviously, if you have episodic hearing loss, tinnitus, and fullness in the ear and vertigo, i.e. many years, then it is worth a trial of many years of beta-histine.
Right, so we're almost coming to the end of this episode. Thank you, it's been really interesting talking to you. It's been brilliant. We're going to do a bit of a quick fire, some takeaways. Okay. So 3 quick fires, okay? What one thing should GPs always do?
I think take a good history and really focus on the mental health aspects of this.
Mental health, absolutely. I will do that from now on. What should we stop doing?
I think maybe don't give beta-histine for tinnitus, because it ain't going to work, or certainly don't give antibiotics, which I've seen before. That definitely isn't going to work.
Good. No medical therapy. And biggest red flags not to miss?
I think sudden sensorineural hearing loss, and actually are they having a stroke in front of you? I think they're the 2 most important bits.
Okay, quite red flaggish.
Yeah, very.
Fantastic. Okay, Marie, thank you so much for joining us. That's been a really enlightening episode. Please do put any questions, comments in the chat below the video, and any ideas for future podcasts in there too. I've been Tom Gillham, Marie Lyons from the Lister Hospital. Thank you very much.